A quick review: the pharmacology of autonomic drugs. Sympathetic. The beta receptor antagonist drugs classify into two groups. We have the non-selective that is going to block the beta 1 and beta 2, and the selective, which is going to block only the beta 1 receptors. Those who are selective for the beta 1 receptors, their name starting with from A to M, and we added for them just like another drug, nebivolol, which because has another action that is producing a vasodilatation because it's going to release nitric oxide. The non-selective starting from the letter N, the name starting from the letter N until to the end of the alphabetical letters. And those, the prototype of them, it is propranolol. As you can see, all of these medication, all of these beta blockers, they're ending with olol, except two drugs that I'm going to mention it in the other slide. Now, some of the beta 1 selective blockers, as you can see, their name starting from A to M. I arrange them alphabetically: atenolol, betaxolol, and so on. So all of them will be starting from, all their names will be starting from A to M, except for nebivolol, because nebivolol have additional activity beside blocking the beta 1 receptor selectively, is going to increase the release of nitric oxide from the endothelial tissue, and that nitric oxide will be diffused in the smooth muscle of the blood vessels and will be produce more relaxation. Now you can see all these beta 1 selective blockers, their name will be ending with olol, except these two medication, carvedilol and labetalol, their name ending with lol only, which means that, just like to differentiate them, they have an additional blockade activity besides the beta 1 receptors. They are going to block the alpha receptors. And labetalol is giving IV. And finally, we have the esmolol. Esmolol also is supposed to be given an IV, have a very short duration of action because it will be hydrolyzed by esterase in the red blood cells, and it's usually given to control the hypertension during the operation or after the operation. Now, these beta 1 receptor blocker, they are going to reduce the mortality after myocardial infarction, because in myocardial infarction, the most reason for death after it is dysrhythmia. And that's because we have an activation of the sympathetic nervous system as a compensatory mechanism. So this agent is going now to block the beta 1 receptors and block the overstimulation of the beta 1 receptors. The same in patient who has heart failure, because again we have an overstimulation of the sympathetic nervous system as a compensatory mechanism. Again, that is going now to stimulate the heart, which it is already, the heart is having a problem. So again, this agent is going to block the beta 1 receptor. So they are going to prevent the increase in the heart rate and prevent the increase in the contractility and so on. Now, these medication, they should not be stopped suddenly, because of whenever you are using a blocker for any receptor, you are going to produce a sensitization or upregulation of the receptor. So if you stop the medication suddenly, now you are exposing the tissue to an overstimulation with the normal neurotransmitter and the natural one, because you have an increase in the number of the receptors. Now, the side effects of this beta-1 receptor blocker, bradycardia, fatigue, and cold hands, it can be understood by the blocking the beta-1 receptors in the heart and decreasing the blood supply to the tissue. The vivid dreams, which it is very strong dreams that it can be remembered directly, that because it is that's this medication will be affecting the function and the release of some neurotransmitter in the brain. And finally, just will mention about that they are going to mask the hypoglycemic awareness, which means if you have a diabetic patient and he is receiving some medication to treat the high blood glucose, so one of the major side effects for this anti-diabetic medication, specifically for insulin, is to produce hypoglycemic effect, to lower the blood levels of glucose. And the patient will be able to be aware about this symptoms or this incidence by having a tachycardia. So now this agent is going to block the tachycardia, so he will not be able to receive and he will not be able to know that he is having a decrease in the blood glucose level. So what will be happening after someone got a myocardial infarction? We have here a sympathetic activation will be taking place in response to pain, anxiety, and acute reduction in cardiac output. Initially, it just like aimed as a compensatory mechanism, trying to increase the cardiac output. However, this activation will be leading to a number of negative consequences. It's going to increase the demand, and in the presence of diminished blood flow, that will be leads to a more damage to the heart. The other one, it will be increasing the possibility for ventricular fibrillation, and that will be leading probably to increase the incidence of sudden death. Besides that, over the time, that will be result in ventricular remodeling and heart failure. So here the beta blocking agents, by blocking the beta-1 receptors in the heart, is going to decrease the contractility and decrease the stroke volume. Besides, is going to decrease the heart rate. So it's going now to attenuate the sympathetic activation and decrease this activation. So, and that is going to stop all of these bad or negative consequences. We have here 3 drugs: metoprolol, propranolol, and timolol. They found that they are going to prolong the survival after the myocardial infarction. Almost we will have the same problem if we have a chronic heart failure. So because the heart is unable to pump enough blood, so then we have an activation of the sympathetic nervous system, and that will be leading to a huge increase in the catecholamine release. And that will be leading to an increase in the heart rate, increase in myocardial energy demand, and it will be leading to remodeling, since we have the cardiac myocytes hypertrophy, and that also will be leading to interstitial fibrosis. Besides that, the beta receptors signaling mechanism, it will be impaired or lost even, And also all of that, it will be increasing the possibility for a serious arrhythmia. So now by using the beta receptor blocking agent, by blocking the beta 1 receptors in the heart, is going now to decrease the contractility and decreasing the stroke volume. Besides, is going to decrease the heart rate. So all of that stuff now, we have three medication. We have bisoprolol, we have carvedilol. Carvedilol also will be blocking the alpha-1 receptors. And we have metoprolol. All of these medication, they figure out that they are going now to stop this effect of reducing the effect of this increase in the catecholamine. And by this way, they are going to reduce the mortality. So we have seen that the stimulation of the beta-1 receptors in the kidney is going to release the renin, and renin is going to activate the system, renin-angiotensin-aldosterone system, beside releasing the antidiuretic hormone. And that will be leading to an increase in peripheral vascular resistance. Now, the antidiuretic hormone and aldosterone, beside that, the stimulation of the beta-1 receptors in the heart is going to increase the increase the stroke volume and increase also the heart rate. So both of them, increase in stroke volume and increase in heart rate, is going to increase the cardiac output. Now, both of them, increasing cardiac output and peripheral vascular resistance, will be leading to an increase in arterial blood pressure and hypertension. So now it will be very logic if we are going to use a medication that will be block the beta-1 receptors specifically. So by blocking these receptors in the kidney, we are preventing the release of renin, and then we are depressing the activity of that system, renin-angiotensin-aldosterone system, and the release of antidiuretic hormone. And also so that will be leading to decrease in peripheral vascular resistance. And also by blocking the beta-1 receptors in the heart, so we are going now to block the increase in stroke volume and increase in heart rate. We are going to block that, so we are going to lead to a decrease in cardiac output. So now the decreasing in the peripheral vascular resistance and decreasing in the cardiac output is going to decrease the blood pressure and is going now to treat the hypertension. Another indication for the beta blocker is in the management of supraventricular and ventricular arrhythmia. We know that the electrical impulses will be starting in the SA node, and then it will be transmitted to the AV node, and then finally will be reaching to the Purkinje fibers. Now, the antiarrhythmic medication classify into class 1, 2, 3, and 4. So in class 2, they are affecting the SA node and the AV node. So by this way, they are going to slow the conduction velocity, and they are going to prolong the refractory period. So the extra electrical activity, it will not be transmitted to the ventricles. Now, those class 2, it is a beta blocker. And just to remember it, look how I will write it. A beta blocker 1 and 2, this class 2. Among them, the most useful one is esmolol. Esmolol, we use it in the acute arrhythmia that will be happening before or during or after the operation. And esmolol has a very short half-life, just about like 10 minutes, so it must be given by a continuous infusion. And it will be metabolized by esterase in the red blood cells. Another drug also related to the beta blocker, it is a Sutalol. However, Sutalol, we classify it as a class 3. And class 3, it is a potassium channel blocking agent. Again, just to remember it, look how you will like class 3. So here we have the potassium channel blocking agent. Look about, so here we have 1, 2, and 3 potassium. Okay, so Sotalol is available orally and also to be given as an IV. In angina pectoris, we have an imbalance between the oxygen demand and the oxygen supply. The oxygen demand, it will be increased if we have an increase in the heart rate, increase in the contractility, and also increase in the preload and afterload. And the oxygen supply depend upon the condition of the patient coronary arteries, and also about the diastolic time, for an example, and diastolic pressure. So in angina pectoris, we have imbalance between the oxygen demand and the oxygen supply. So using the beta blocker agent, by blocking the beta 1 receptors in the heart, is going now to a decrease in the contractility, and decreasing the contractility will be leading to decrease in the stroke volume, and also will be decreasing the heart rate. So all of that stuff now, decreasing the heart rate, decreasing the contractility, that is going to decrease the oxygen demand and will be improving the oxygen supply demand balance that we are looking for in the heart. Here we have atenolol, metoprolol, labetalol, and carvedilol. And again, as you can see, that we have the labetalol and carvedilol, those ending with lol only, not olol. They are also blocking the alpha-1 receptors. So these agents, they are useful in the management of angina pectoris, beside the other specific medication for this condition. Another indication for the utilization of the beta blocker, as we already mentioned almost like several times, is in the management of glaucoma. So we know that the aqueous humor will be secreted from the ciliary epithelium, and we have the innervation, the sympathetic nerve terminal will be releasing the norepinephrine, which will be interacting with the beta receptor in the epithelial cells. And also we have the circulating epinephrine that will be interacting with the beta 2 receptors also, and that will be going, the stimulation of these beta receptors is going to increase the production of aqueous humor. Now, using the beta blocker in the management of glaucoma, we have this medication, betaxolol, carteolol, levobunolol, and metibranolol and timolol. Now, this agent, the first one is a selective for the beta 1 receptors. The others they consider as a non-selective in this condition, and they are going to, by blocking now these beta receptors, they are going to decrease production of aqueous humor and useful in the management of glaucoma. Another indication for the beta blocker is in the hyperthyroidism, specifically for the propranolol, which is going to decrease the heart rate and also decreasing the tremor. Besides that, we know that in hyperthyroidism, the thyroid gland will be releasing T4 about 80% and T3 about 20%. Now, in the body, in the liver and in the kidney, we have the transfer of the T4 to T3, and T3 is the most active or more potent than T4. So propranolol is going also to inhibit the peripheral conversion of T4 to the more active form, the T3. So by this way, it will be useful in decreasing the symptoms and signs of hyperthyroidism. In the migraine headache, the beta blocker, they have a prophylactic effect. Here we have the bisoprolol, metoprolol, propranolol, timolol. And we have another two drugs, atenolol and nadolol. They have a moderate effect in reducing the migraine attack frequency. It had been proposed several mechanisms for the prophylactic effect of the beta blocker in the migraine headache. All of them almost like depend upon that they are producing their prophylactic effect by blocking the beta-1 receptors. So they propose several mechanisms by inhibiting the noradrenaline release and reducing the neuronal firing rate of the noradrenergic neurons. Besides that, they are inhibiting nitric oxide production, and also they are blocking the serotonin receptors type 2, C, and B, and affecting also the serotonin production. This just I mentioned some of the proposed mechanism for the prophylactic effect of beta blocker upon the reducing the migraine headache attacks. Another indications for the beta blocker is in the essential tremor, and probably one test just like to see it, to see if the patient have an essential tremor, is just like to ask to drawing a spiral. So here the spiral, I draw it by my hand, that looks okay. If somebody have an essential tremor, this is how it looks. So here in this condition, probably one of the most usable beta blocker is propranolol. We start with a low dose 60 milligram up to 320 milligram per day. By blocking the beta-2 receptors in the muscle spindle fibers is going to reduce the tremor. Another indication for the beta blocker, the same again for mainly for propranolol, is what we call it the stage fear or the performance anxiety. We know that the person who is going to speak to public, he is having a rapid heart rate, increase in the heart rate, and he is shaking and feeling just about to collapse and so on. Okay, so usually here, if we give propranolol 10 to 20 milligram, just 30 minutes before the public speaking is going to improve it. And for those who are in the beginning of this type of public speaking, and then after that he will use to it. Now, some of the side effects that will be produced by the beta blockers, it will be very easy to be explained. So we know that they are going to produce bradycardia. That's because, again, they are now blocking the beta-1 receptors in the heart. The same, because they are blocking the beta-1 receptor in the heart, they are going to depress the myocardial contractility. And also they are going to depress the excitability of the heart, because some of these beta blockers, they have also a local anesthetic action. So that they produce what they call it membrane stabilization. So that will be decreasing the excitability of the cells. Also, they are going to produce some kind of fatigue, mild sedation, vivid dreams, and sometimes they might be leading to depression. That's because if some of them will be crossing the blood-brain barrier and will be affecting now the production and release of the norepinephrine and some other neurotransmitter in the brain. Also, they are producing a cold hands, and the same, they are going to be worsening the pre-existing asthma. So the cold hands, it's understandable because they are going to block the beta-2 receptors in the blood vessels, which usually is the stimulation of the beta-2 receptors in the smooth muscle in the blood vessel will be leading to vasodilatation. So now you are producing vasoconstriction. The same can be explained with the worsening of the pre-existing asthma, because again they are blocking now the B2 receptor in the smooth muscle in the bronchi. And they are masking the hypoglycemic awareness. Those who are receiving some medication to control the blood glucose, like insulin, for an example, the major toxicity or side effects to produce hypoglycemia. So the patient will know that he is hypoglycemic whenever he has a tremor and increase in the heart rate. So the beta blocker will be preventing the tremor and the palpitation, so he will not be able to know that he is suffering from hypoglycemic effect. And at the same time, they are going to prevent the adrenaline from stimulating the liver to make more glucose. And now for the last type of the beta receptor, the beta receptor type 3. This is present in the bladder and also in the adipocytes. We're starting with the one present in the bladder. So here we have a bladder. I'm just drawing it in my hand. And here we have the ureters. We have the urethra. And here we have the innervation for the bladder. Now, in the bladder wall, we have a detrusor muscle. And the bladder, as you already know, is just like a storage for the urine. Now, the relaxation of the detrusor muscle, it is a smooth muscle in the bladder wall, will be prevent the urination and will be making now the bladder to have a more volume of urine, to accommodate more volume of urine. So we have one drug that will be stimulating the beta 3 in the smooth muscle of the detrusor muscle. This medication, the name is mirabegron, will be taken 25 milligram orally within every day, and it will be effective within about like 8 weeks. So the major utilization for it in the overactive bladder. And the overactive bladder, what we mean by that the bladder usually it will not be able to accommodate even just like a few cc of urine. The patient is running and feeling that he needs to urinate and he will be running to the bathroom. So by using this medication now, we are producing relaxation of the detrusor muscle, and now the bladder, it will be able to accommodate more volume of urine. The side effects of this medication, it may be increase the blood pressure, specifically if the patient he's already have hypertension. Okay, the other presence now for the beta 3 receptors in the adipocytes, and the stimulation of this receptor will be increase the lipolysis from the adipose tissue.